Welcome, everyone. And keep seeing people coming in, but we're going to go ahead and get started because we have a timed event today. So, welcome. I'm Dawn Ellison. I'm in the core group of Healthcare Reinvention Collaborative, along with Denise Wiseman, Wael Sasu, Jennifer Beach, Keely Gales, and Paul Burens. So, after our robust exploration about how we got to where we are in healthcare last month, we decided to invite back our three guests from that discussion and throw a bit of a rebel into the mix. So, today's discussion is about the scale of solutions, and we are using a slightly modified version of the intelligence squared debate techniques for those of you who are familiar with that. The proposition we will be addressing today is America's healthcare future lies in national systems, not local solutions. Is healthcare reform best achieved through unified national systems that standardize care and distribute resources equitably? Or do we need a mosaic of local innovations adapted to community needs and circumstances? Before I introduce our guests, I'm going to ask each of you to weigh in on that poll that Denise put up. And you can see what that reads there. That is our proposition. We will be having people arguing for that proposition and against the proposition. So the format of the event today is that there will be leading arguments by our two teams, and I will introduce them shortly. Those leading arguments will take a total of 7 minutes each side, so 3.5 minutes per guest. Then we will have about 10 minutes of moderated discussion where I will be asking our teams some questions. And then the next 10 minutes or so will be them directly asking each other. So the opposing teams will have a chance to ask some pointed questions of each other. Then we will have audience questions. I know you'll be waiting for this one. You'll probably be thinking of some good questions, and we'll have you either put your mics on and ask those, or perhaps pop them in the chat. So there will be time for audience questions for sure. And after those 11 minutes are up, then we'll have final arguments, 2 minutes each side. And then we'll put this poll up again, and the winner wins over the most people. So the winner is not the one who has necessarily the most votes, but who has shifted more people to their point of view. Okay, so let me introduce our panel.
Do you want me to quickly, share the poll where it currently is so that people can
Sure.
see? So
Oh,
I'm
yeah.
going to end the poll, and I'm going to share results, and I've taken a screenshot so we can identify at the end.
Oh, wow. Tied with agree and disagree, and then a big chunk of undecided. Excellent.
Republicans, Democrats, and the rest of us.
So I'll start spotlighting while you introduce.
Okay, sounds good. All right. So, in favor of the proposition that America's healthcare future lies in national systems, not local systems, we have two guests. The first is Michael Millenson, and I will introduce both of these guests and then I'll ask them to make their arguments. Michael is a former Chicago Tribune healthcare journalist who, after receiving 3 Pulitzer Prize nominations, transitioned to become a nationally recognized expert on healthcare quality and patient safety through his groundbreaking book, Demanding Medical Excellence, Doctors and Accountability in the Information Age. Dr. Stephen Bezruchka is an associate teaching professor emeritus in health systems and population health at the University of Washington School of Public Health, whose influential research and advocacy focus on how economic inequality leads to poorer health outcomes in the United States compared to other developed nations. So, Michael, we're going to start your timer and have you tell us your leading argument.
Well, thank you. So some years ago, a physician friend of mine from Chicago was dispatched to a southern hospital to talk with the chief medical officer there as part of his job about the fact that some of the care did not follow national guidelines. And the southern doctor listened to him very closely and then said, well, you know, Dr. Jones, we do things differently here in Georgia. And my friend thought for a moment and responded, well, you know, Dr. Smith, I didn't know the New England Journal of Medicine had a Georgia edition. And so with that kind of setting, All healthcare is local goes an oft-repeated saying, but the question we should ask is which healthcare is appropriately local, and not to mention, what do we mean by local anyway? In other words, which aspects of national healthcare reform demand national initiatives, and what should national reformers with really nice intentions leave alone so their good intentions don't muck up things at the local level? So here's what the evidence shows. If you truly want to fix American healthcare, you can't help but focus on a national solution. So let's do the numbers. Census Bureau data show that as of 2023, 92% of the US population had health insurance, or about 305 million Americans. Roughly 19% on Medicare, 19% on Medicaid, 3% on TRICARE, 1% on VA care. That's 42% of the total. I can add, of the remaining privately insured population, about 17% were enrolled in federally regulated ERISA plan. So that adds up to 59% of those insured, or about 180 million Americans who are essentially exempt from local governmental initiatives. And yes, there are state waivers, but the feds have to grant them. All right, so let's go back to my friend's visit to Georgia. Do you believe your anatomy changes depending upon where you live? If so, then regional variations in spinal surgery or other procedures won't bother you because all healthcare is local. Although I've always wondered how long you have to live somewhere before your body adjusts to the local anatomy. If you're a tourist, do they call back to my doctor, Roger? And then again, what do we mean by local? A recent JAMA study based on more than 40 billion insurance claims for 148 health conditions found as much variation among different counties within states, with the usage of healthcare services accounting for 2/3 of the variation as among states. So maybe your anatomy changes every time you cross a county line. No wonder your body gets so tired when you go driving for a long drive on vacation, all that changing back and forth. Now, could non-medical political and business leaders really tell local doctors, each of whom genuinely believes they're doing the right thing for their patients, that they must change? That's been repeatedly proven a non-starter. Yes, focused local programs can and should be an inspiration for national implementation, and national big ideas should first be tested locally. However, local healthcare innovation will not diffuse and may not even survive without national support.
Thank you, Michael. Stephen, you're up.
All right. I'm going to suggest that the debate topic is asking the wrong question. My perspective comes from experience in 3 countries. One is Canada, where I practiced in British Columbia. Another comes from some 11 years spent in Nepal, including setting up a community health project a week's walk from the road, setting up a remote district hospital as a teaching hospital for Nepali doctors, and working as an emergency physician here for 30 years. So healthcare can treat illness and injury, but the lack of healthcare is not the cause of illness and injury. So we in this country have worse health and die younger than people in all the other rich countries, and a considerable number of less rich ones, such as Chile, Qatar, Turkey, Thailand, and Slovenia. Our life expectancy is about the same as Cuba's, a country we've been strangling for over 60 years, and I would argue we're tightening our own noose. To achieve this, we spend half of the world's healthcare bill in this country, some $4.5 trillion, or a sixth of our total economy. At the government level, we already spend more on medical care than all the other nations which have universal or Medicare for all, but this still leaves more than 50 million people here with limited or no access to medical care. So all studies demonstrate healthcare is a minor player in producing health. Study from Stanford suggests about 10% of avoidable mortality can be impacted by medical care. Another study from Johns Hopkins shows medical care as the 3rd leading cause of death. To corroborate that, when we go on strike, undertakers have less work to do. So when the public is asked, do you want health or healthcare? They're confused because our language doesn't serve us. We access health, pay for health, get health, insure health, when all that refers to healthcare. So no wonder the public believes healthcare is the key factor in making people healthy. So we're asking the wrong question, as Thomas Pynchon wrote in Gravity's Rainbow. If they can get you asking the wrong question, they don't have to worry about the answers. So however, to address the debate topic, it's clear that a national healthcare system devoid of profit that offers needed services to everyone at point of delivery without having to pay is needed. We can certainly afford that. But doing so won't make a dent in our being dead first, namely pushing up daisies far before our time. And this is true for all of us. No one escapes an early death here. So educating the public about this needs to begin and start in grade school, since it's much harder to get older people to accept new ideas. But that's for another debate.
Thank you, Stephen. All right. So against the proposition, we have Emily Peters. Emily is a healthcare brand strategist, founder of Uncommon Bold, and author of influential books, including Women Remaking Medicine and Artists Remaking Medicine, who draws from her near fatal childbirth experience to advocate for maternal health and healthcare transformation. And we have Dr. Jeff Goldsmith. Jeff is a healthcare futurist and president of Health Futures Incorporated, who combines decades of industry experience with exceptional analytical skills to forecast healthcare trends, providing strategic consultation to healthcare systems, health plans, and technology firms. Emily, let's hear your argument.
Wonderful. Well, I think this is an interesting debate because fundamentally we all agree on one thing at the start, which is that what we are doing now is not working and has not been working for quite some time. So we're starting from a place of agreement. We know that we have the world's most expensive healthcare system, that we have failing outcomes. It's almost a cliche now to bring up that talking point. So the question is, what do we do about it? And the definition of insanity is to continue doing the same thing and expecting a different outcome. And I would say that the experience of our healthcare system over the past 40 or 50 or 60 years has been about implementing increasingly large national systems of healthcare, both through the public side with the implementation of increasingly large administrative burden around CPT, ICD-10, RVUs, HEDIS, et cetera, increasingly heavy administrative burden that has led to a 3,200% increase in administrators compared to growth of other types of clinicians and direct providers. On the private side, we have seen vast national consolidation to the point where most metropolitan areas in the US only have one, maybe two health systems that are available to patients in their communities. Most people are covered by one of 5 private payers in the US, and that does not even account for the 59%, as Michael said, who are covered from a national healthcare system. So should we continue to try the same thing and do national approaches to healthcare, or should we try to think differently about our system? As Michael said, yes, your anatomy does not change as you go between counties or states, but certainly the culture changes, and certainly the psychology changes, and certainly the needs of that community change as you go between. And so my advocacy point here is that if we are trying to really change the outcomes and that 90% of health that comes from outside the healthcare system, outside the surgical unit, outside the emergency department, we should be thinking locally and from a cultural perspective of cutting out those big national middlemen, giving communities the trust that we enable them to lead their own way forward and to do the things that we know are going to truly change the health outcomes for their communities. We're talking about things like access to primary care, making sure that our rural hospitals are able to be open for things like delivering babies, reduction of poverty in our communities, building trust and collaborative spirit into our healthcare system so that a community together says, this is how we are going to get healthier. And these are the kinds of new ideas that we need that are rooted in our local communities, that are trust-driven, not necessarily evidence-driven, that will actually change the health outcomes for people in our community. And we have seen powerful examples of this at work: San Diego 2-in-1, Laguna Honda Hospital, increased social care networks, roles like that. And we can talk more about how those programs are working. But I think it's a mistake to say that the national approach has been working. And I think it's a point of hubris to say that the national approach knows better than the people in their own communities.
Thank you, Emily. All right. Jeff, can you bring it up?
Yeah,
wind us up?
I think so. 52 years ago, President Richard Nixon signed the HMO Act of 1973 into law. The HMO Act of 1973 was the spiritual godchild of Paul Ellwood, who believed that instead of having a national healthcare system like Canada or a lot of European countries, what we needed was to foster competition in local markets between health plans modeled on Kaiser Permanente. The idea that you'd enroll in a health plan, you'd have multiple choice of health plans with a fixed employer contribution. And once you enrolled, those health plans would manage the care of the patient in a fixed budget resulted from capitated payment. It took 20 some odd years to build the infrastructure to do this. By 1996, about 31% of the employed population in the US was in an HMO. And then a backlash set in, not dissimilar to the backlash that's underway now with the reaction to United Healthcare. And by the mid part of the first decade of the aughts, or the end of the first decade of the aughts, the number had fallen to 13%. What happened? Well, in a lot of places, HMOs just didn't get the support of the medical community or the care system that it needed. It didn't get the support of the employers in those communities that felt that their local Blue Cross plan or national indemnity carriers were perfectly adequate to care for their patients' needs. And then a whole bunch of them failed and were rolled up into what is today United Healthcare. Kaiser's still with us. Kaiser's done an exemplary job, but more than 80% of its enrollment is in the same Pacific Coast states that it started in 80 years ago. So, the idea that, I think the HMO Act of 1973 was a recognition that the political support for nationalizing our healthcare system wasn't there. And the subsequent performance suggested to us that a national template imposed on local communities probably wasn't going to prosper either. I think the problem is that this isn't really a country at all. Colin Woodward, in his 2011 book, American Nations, basically said there's 11 American nations and did a pretty convincing job of demonstrating that these different nations have been fighting with one another over values and territory and resources and political philosophy for most of the last 250 years. So, the idea that a national system ought to happen when our national institutions are completely paralyzed, cannot even pass a budget. It is hard to believe that an entity that clumsy and paralyzed is going to be able to manage effectively a $5 trillion economic activity that affects all of us. So I'm kind of with Emily. I think there's a lot of energy behind local initiatives. My favorite model of this is Montefiore Health System in the Bronx that is now pushed out and is a regional enterprise, the poorest community in the United States. They've done a spectacular job of improving the health of their community against terrible constraints.
Right on the button. All right, thank you. So you've heard the opening arguments. Now I have a few questions to ask the teams. And this segment will be about 10 minutes long. So first, for the local team, Emily or Jeff, you argue that local systems foster innovation, but they can also entrench parochialism and resistance to outside ideas. Without national mechanisms to identify, validate, and propagate best practices, how do you ensure that effective innovations in one community actually reach and benefit patients in other communities?
Jeff, would you like to go first?
Yeah, I mean, there are national elements to our healthcare system. As I think Michael pointed out, we have Medicare is national. The National Institutes of Health, what's left of them, are national. The body of scientific knowledge that we have that ought to inform medical practice is national. So it's not like there isn't a national influence. The issue is the salience of those entities and what they end up doing in local communities to foster better care. I believe the Medicare program has an obligation to be a prudent purchaser of health services for patients, regardless of where they live. And that is going to mean sending signals to medical communities and to health systems about what we want them to do. So I'm not arguing that that isn't important, but I think it's the constraints that are placed upon the ability to change healthcare in some systematic way by all this regional variation that I'm kind of concerned about. And Emily might have some other thoughts on that.
I think this is the separation where we talk about the definition of what is healthcare, right? Certainly for surgeries and cancer treatment, evidence-based national, moving together, the science of that is important. But when we talk about getting somebody to get a flu shot, right, getting somebody to get their insulin, to be living a healthier life, to have access to food and primary care, that is a different framework. And we know that is the side of healthcare that is really failing today. And that is the side of healthcare that truly delivers health outcomes. And in that way, I think that is where our local communities are much more equipped to lead innovation there and to share. I mean, I think we do see today communities sharing and growing those expert best practices, you know, the Council of Governors, the Council of Mayors, getting together, talking about what works and doesn't work in their communities.
I'm going to switch to a question for the national team. Stephen, what do other countries where people are healthier do that we could learn from? And is this done on a national level?
So, a very important point. Other countries, first of all, we're the only rich country without a universal healthcare system. So off the board, that's needed. But the other countries provide what's necessary to make a population healthy. Two factors matter most. One is the gap between the rich and the poor. Inequality kills. It's the title of my book, Inequality Kills Us All. And the evidence for that is damning. It's what puts us in our graves far too soon. So we have the most. We have decided to take from the poor and give to the rich on the order of $79 trillion from 1975 to 2023. That's what the Rand Corporation says. How much is that? Well, if we had a stack of freshly minted bills to reach 79 trillion, it would take us a quarter of the way to the moon. That's how much we have willingly given to the rich so they can be richer. That has to stop. The other factor is attention to early life. There are only two countries in the world that don't give a working woman who's pregnant paid time off after she has her baby. One is, of course, the United States, and the other is Papua New Guinea, half of a big island north of Australia. If we want to live, if we don't want to push up daisies too soon in our graves, those are the two things we need to fix. And that's what other countries do that we can learn from.
Thanks, Stephen. Michael, I've heard you mention that primary care is proven to improve outcomes while lowering costs. How would a national solution prioritize and strengthen primary care access in ways that local solutions cannot?
Well, there is no reinvention without reimbursement. So if locally you can let primary care doctors be innovative and not go out of business, that's terrific. Unfortunately, what we've seen is that primary care docs do not have the political and economic clout that some of the others do. And they haven't been able to do that. So sure, let's do it. Now, nationally, we've seen some spectacular failures with the Village MDs and others of the world, but they've been bought and, you know, national players try to make things happen nationally that shouldn't. So I think one of the points that Emily brought up that was very good is talking about local culture. Primary care is often about local culture and local relationships, and that needs to be there. Whereas if you refer, on the other hand, if the primary care doctor believes that the local surgeon who operates, you know, on anybody who has a pulse is a great surgeon, you know, what good does that do you, right? So there's that balance, and we need national reimbursement of primary care. The obvious example is the Medicare wellness visit, which you can't call an annual checkup, right? Now, Jeff's shaking his head, right? Whether that's been worth anything, and there's the whole literature on that.
I have one every year.
Right, and the point. And it's bizarre. The point is that when national policy encourages primary care, it gets done, good for good and bad. And when it doesn't, when there's not reimbursement, it doesn't get done. Actually, what we should do is we should take away the ability of the American Medical Association to write all the reimbursement codes and turn that over to the primary care physicians and say, would you please rewrite all the reimbursement codes? And then all of a sudden we might have a different healthcare system. But, you know, innovation needs money. And we have totally deprioritized primary care, both for our medical school students and elsewhere. And if now, one last thing on local, some corporations have on-site medical clinics with local people. That's great, right? The corporation pays for it, all the rest of that. But again, these are kind of pinpricks in the issue. So good luck with some of these local initiatives. We need them, but it's not apparently solving our problem nationally.
One more question for the local team. Some aspects of healthcare require highly specialized expertise that simply can't exist in every community, from rare disease to cutting edge treatments to complex public health modeling. How do locally controlled systems access and implement specialized knowledge that may only exist at the national or global level?
I mean, you've made an argument that we can't do without national standards and a national knowledge base. And I don't think anyone's arguing with that. The question is whether you can dictate a particular structure or organization of medical care from Washington. And I don't think you can. And, Michael, I mean, it's pretty obvious what happened to primary care. Primary care was destroyed by the Part B fee schedule. A national Part B fee schedule basically destroyed primary care and pushed physicians into salaried employment by hospitals, which was then trued up by clinic fees and site of service payments to the point where, we now have a very expensive primary care system that's hospital driven. That was national health policy, sir.
You don't think it's because the reimbursement for doing things is so much higher than the reimbursement for the thoughtfulness that
Who wrote the rules?
Yeah, who wrote the rules as a national?
The government influenced by the surgeons and all those guys. It's not like the government wasn't influenced by those folks.
Well, and until you get rid of Citizens United, which basically argued that political contributions are protected First Amendment free speech, the practical consequence of which is $400 billion United Healthcare as a person.
And
private totally outnumbered by a $400 billion entity. So we can talk in theory about how great it would be to have national something, but if you've got $400 billion people striding around the corridors of power, guess what's going to happen?
And just to quickly, go ahead. Sorry.
I was just going to say, we're moving into cross-examination already because we want to. So let's move into that. Emily, I'll give you the mic first. We've got about the next 10 minutes of cross-examination where each team gets to ask questions of the other. And generally, this would be you ask a question, the other answers, you have a brief follow-up, and then the other has an opportunity to rebut as well. But I'll let you guys just kind of take the course as you will.
Sure.
So Emily, go ahead. I'll let you jump in first.
I'll follow through on that piece of access to specialty care, right? The former question. And so, patients are very willing to travel to access the highest quality specialty care, both, here in California, going to Stanford, going to UCLA to access, you're not going to have a neurosurgeon in a rural county. And that's not necessarily something that you need to have in a rural county. That patient is willing to travel. When we talk about local, it's about equipping those local communities to build the access to the everyday care and the everyday health elements that they are truly missing. And so I guess my question to the affirmative team here is, give me an example of a time that a national policy has made that piece of American healthcare better in terms of the local access to things like primary care, to public health interventions. And maybe that's a place that we could start, not the surgeries and the oncology and the highly specialized care, but the everyday public health interventions that have worked. When has that really worked effectively from like a national standards perspective recently?
Stephen, do you want to start?
I can speak. Remember when doctors, and I worked as one for 40 years, when we go on strike, morticians have less work to do. Documented in Los Angeles, in Israel, in Bolivia, many studies like that. So we're asking the wrong question. Do we want local or national health care? We need to ask, do we want health or health care? And, I pointed out that we die younger than people in 40, 50 other countries. Our three leading causes of death in 2022 were heart disease, number 1, cancer, number 2, unintentional injuries, number 3. If we eradicated those 3 leading causes of death, we'd be almost as healthy as Japan. Mm-hmm. So the gap in our health is huge, and there's no way that we need to change our language, but healthcare is not going to do it. So you spoke of health system, health plan, health insurance. All those refer to healthcare, and we're asking the wrong question. We need to figure out what we need to do to make the country healthy, not to provide healthcare.
We know one of the things that I've always wondered about is, this idea that the health system, whatever you want to call it, that institution that consumes the $5 trillion a year, is a black box where you put money in one end and you get health out the other end. I think that's a completely broken notion. And most national health policy focuses on fiddling with what goes on in the black box to try and improve the return on the $5 trillion. The reality is a lot of that $5 trillion is just repairing damage done to people by a toxic culture that has poisoned us. And results in a lot of the premature deaths, Stephen, that you talked about. So how do you change the culture? How do you change the things that make people sick, that put them in the emergency room in the first place? I think that's the conversation we ought to be having.
So let me jump in real quickly. A short answer to Emily's question: federally qualified healthcare centers.
There's a good one.
And some of the rural health initiatives and some of the outreach and the VA. There's a long list of back in the day. But of course, what those say, and it goes to what Stephen and Jeff were both saying, is what's our culture and our social contract? Americans do not believe in prevention. We do not believe in making people wear helmets when they go motorcycle riding. We do not believe in saying, if you don't wear a helmet, you'll have to pay for your own health care if you have a crash or sign this distribution thing. We do not believe, look what RFK Jr. is trying to do with processed cereals and all the rest, and they're all coming in. We do not believe that if you do something that causes you to have bad health outcomes, you should be responsible for it. That's against the law by and large to discriminate. So Louisiana, you talk about trusting local communities. The problem is that we localize benefit and socialize risk. So Louisiana has a 40% obesity rate. Should their people pay a higher Medicare insurance rate than the people in California who are going jogging all the time? You want to trust local communities? Great. Trust, you have kids, right? If you do something wrong, you also have to bear the consequences. The consequences are into the national taxpayer, and the trust is local. We as Americans believe in choice and freedom, right? So even in defense, I used to write about defense. We like billion-dollar submarines and billion-dollar aircraft. We do not like, paying for drones and artillery and better, uniforms. And we love high tech. We love MRIs rather than giving people, eating better. That's who we are. And that's who our lobbyists are and all the rest of that. So in fact, if you want to change culture, that's, fine. So what's the consequences if you don't change the culture in terms of what I am paying for as a taxpayer or even as a corporation? If I'm an ERISA plan, okay, and I'm a Taft-Hartley plan, I'm covering auto workers. Tell me the success that you're going to have as a Taft-Hartley plan going to say, you know what? We're going to have our auto workers who are obese and go motorcycle riding and whatever pay more in their premiums than the people who have healthy behaviors. Ain't going to happen. And so if as a country we're going to socialize risk and personalize benefit, we have an issue. And even RFK is going to have problems with those sugared cereals and all the rest. So I agree with you all, but the problem is that culture is hard to change. And if you don't change, are you going to pay any financial penalty, or I'm going to pay for your motorcycle riding into obesity?
Is that an argument for a national solution, Michael? Because if it was, right over my head.
It's an argument that while we are saying we're having the wrong conversation, we should talk about changing culture. Yeah, but if you look at local solutions, will they scale nationally? No, they won't. However, however they eat in San Diego is not going to affect how they eat in Baton Rouge. But it's possible that things will change, but they change slowly. So if we're going to talk about changing American culture, that's a different conversation than changing the healthcare delivery system.
So I would love to, I think your FQHC point was a really good one. I want to double click on that one a little bit more, because FQHC absolutely is a local initiative that is supporting rural health, that's delivering primary care. It also has, so that's the positive. We like that for the local side. The negative side, the administrative burdens on an FQHC are significantly higher than a traditional medical practice, right? And so the national system is sucking the lifeblood out of the FQHC while it is also funding and creating that FQHC.
So let me apply to administrative burdens, which we all like to pick on, along with fraud and abuse. Yes, I couldn't agree more, but I'm going to say it with an asterisk.
Yeah.
There is nobody in government who makes up administrative shit just for the hell of it. They
it's
do
all
it
good intention.
They do it to respond. They do
Yeah.
it to respond to abuses. And the
Sure.
problem we have is we need to figure out a way, like Ed Paul Burenger has talked about, where you made the primary care person a gatekeeper and let doctors manage medical care. You took care of some of the abuses as opposed to the administrative stuff. We need to show that if we do trust, we don't just get ripoffs. It's
So
like if you're
I love
and that's
this,
the problem.
this point, because I do think there is a bias in our country that we say a national system paternalistically is going to be more trustworthy, it's going to have more legibility than an individual community which could rule itself and can catch its own issues and can solve things. I don't necessarily think that choice, that the national system is less susceptible to administrative burden, to fraud and overreach than a local community. I don't think that's a true framework. And I think we should let that go. I think we should have more trust in our communities. They will make mistakes. I mean, the example that I'd like to share for the local community is our local hospital here in San Francisco called Laguna Hondo. It's one of the only almshouses, like 2 poorhouses. Oh, never mind. I can't get into my story. I can share it later.
All right. That was our cross-examination section.
I just want to have a quick response. I love what you're saying, Emily. I live in Chicago, trusting the local people that they can take care of fraud and abuse better than the national government in Chicago, in Louisiana, and a lot of other states I claim. That's a really nice thought.
I think it's paternalistic to say that there would be less. I think that fraud everywhere all the time.
So I just want sarcasm alert on the part of Michael.
But we're good at it here.
All right. So now is our opportunity for the audience to ask questions. And I don't know if Paul or Denise or any of our core group has seen any questions come up in the chat, but I invite you all to speak up, raise your hand if you have a question for our 2 teams. We have a national team and a local team.
Dawn, I and others have been putting editorial commentary in the chat, but I haven't actually seen any legitimate questions.
Okay. A comment would work.
I think Judy was maybe going to say something.
Judy,
You
you're
turn on your
muted
mic.
still. We can't hear you, Judy. You're muted.
You're muted.
Okay,
There you go.
Sorry.
There we are.
sorry.
You have a
Mine
question
is,
for the panel?
no.
Do you have a
Nothing
comment? Go ahead,
nothing
Judy.
I can resolve. It wasn't that. It was a comment that
Okay.
was out there about a deep fat fried battered stick of butter in Louisiana.
True.
True.
That's when they ran out of Snickers bars.
No, deep fried butter is my favorite example, actually, of one of the state fairs. Yes,
Oh my God, there is such a thing.
there is such a thing.
We have a
But I
question.
trust. I
Yes.
trust.
Do you see
the
a
state
question?
fair.
Trisha
Denise?
Choi says, just because change takes slow, does this mean we don't work towards that strategically?
No, that's a really good point. I think we need to make choices. We can't have 10 national health priorities, 3 maybe. And we need to put resources behind the 3. And we need to publicize the people that use those resources to really move the needle. I think it is the absence of focus exemplified by Obamacare. You know, a huge good deed providing 30 million people with health coverage, but 930 pages of technocratic tinkering that, believe me, as a health policy expert that tried to read it, was absolutely baffling, even to somebody that had been in the field for a long time. So the technocrats have really, we've let them go crazy. And they've created an administrative superstructure that is completely unsustainable and has by itself made a major contribution to creating the shortage of physician time and effort that we have today. We created that shortage by diverting half of our clinicians' time into typing.
So I have to sort of speak out against Jeff's use of the phrase health policy. It's healthcare policy, and
Mm.
nobody so far is asking anything about the fact that we're dead first. That none of us in this country can expect to live the long and healthy lives of people in all the other rich countries and a considerable number of poorer ones. And it's not personal behaviors. I used to believe that healthcare and personal behaviors really mattered. And then I mentioned Japan, the longest lived country. Then I learned that Japan had more than 3 times as many men smoking as in the United States.
Mm.
And in the ER, I used to rail against my smokers.
Mhm.
Then once I realized that Japan had these behaviors, I had to reflect and say, hey, behaviors aren't as important as I used to think. What really matters, I think Jeff said it, and Michael, culture. So what is it that allows Japanese to smoke like chimneys and not die young? Well, their culture of social solidarity.
There you
Do you
go.
ever see a lone Japanese tourist?
Mm-mm.
Do you ever see a lone American tourist?
Well,
Great
Mhm.
question.
It sounds like we went over Stephen to the local side, so that's
well,
great.
let's talk about social solidarity because that's also a national thing. It's both local and national. So let's talk about social solidarity. Right now, the Environmental Protection Agency is run by an individual, Trump. They're taking away protections against a lot of pollutants, against all sorts of kinds of things here. We're going that throughout our society. We're taking away protections against microplastics, against emissions, and all the rest of that. Do you see a societal rebellion against that? Do you see people from red states and blue states alike rising up and saying, we may disagree on immigration or on this, that, or the other, foreign policy or tariffs, but we all agree about the sanctity of human life, and we need to have pollution controls and clean air and electric vehicles and all the rest? Well, you don't. And we as a society, Stephen showed his book talking about inequality. We as a society believe inequality is good. It shows that the good capitalist innovators are rising to the top, and those of you who haven't read your Horatio Alger are going to the bottom. And what the national technocrats have sometimes done very wrongly is try to fix all that with 940-page text. On the other hand, they put in the Affordable Care Act. They gave everybody the access to the marketplace to get health insurance, where many of us couldn't have gotten it before with pre-existing conditions and the rest. So there's a mixture of people who try to ram culture change through appropriately and inappropriately. But as a country, we believe that inequality shows that I'm better than you are.
But,
Otherwise, I wouldn't be
Michael,
rich.
I mean, for, the next 10 years after the implementation of the Affordable Care Act, American life expectancy plummeted. So what's the connection between all that stuff and the things that we've been talking about, what we'd like to get better? Okay. It's not clear that expanding coverage, it's not clear that expanding coverage had anything to do one way or another with the decline in life expectancy. But something rotten in our culture is continuing to kill people before they ought to go.
I think the argument for local here, to me, is also an argument for listening to what communities want versus telling communities what they need to have. Right?
Perfect. We should
I think-
enter then, we should bring in then the audience that is putting stuff in the chat room.
Sure.
Yep.
First of which, Marlene Seiden says, is there one thing we could do nationally that would improve health for Americans physically, such as making a food item healthier? Anybody want to address that?
Yes, very easily. We just need to tax the rich. Who pays the lowest rate of tax on combined federal, state, and local incomes? The richest 400 families, 23%. Back in the 1960s, they paid over 70%. So we've decided to not have the rich pay tax and to go into massive debt and everything else. So a simple solution, which is off the table, let's tax the rich.
What does money have to do with this, Stephen?
Yeah, how does that, if you put the money into buying a new billion-dollar submarines, I'm not sure that improves health. I mean, you have to do
Or
something.
more HEDIS reporting, more.
So what is
right?
what does a big gap between the rich and the poor do? It causes more stress.
Well, okay.
Studies on passenger airplanes, which have a first-class cabin, if you enter through the first-class cabin, then there's more stress, there's more bad behaviors in first class as well as in coach. If you enter behind the first class cabin, then the rich aren't so wigged out. If there's no class distinctions, there's less air rage.
I
We
do
found
agree
that-
that disparity is a huge issue, but this is again a place where I think local can help solve this more, right? Because people are saying, I want people in my town, in my county, or in my state to live healthy lives, to be safe. That's an easier cultural sell than to say nationally, this massive country of 300 million people, I want to try to create this program.
Wait.
Unknown
Emily, so I want people in my state on Medicaid to work, and I'm going to ignore the fact that often they can't find jobs, and if they have no health insurance or no benefits for welfare or anything else. So Mississippi is your national model for how we have to trust people. We shouldn't have people on Medicaid. We should be maybe in Texas with 25% uninsured, and that's going to lead to healthy lifestyles like you see in Mississippi and Texas and
Boy,
places
we're,
like that.
we're doing an awful lot of crapping on the South, Michael. No offense.
Well, no offense.
That's so cool.
Wait a second. It's not like we're all healthy in Illinois. I live here, or in Minnesota, or any place else. The fact is that Mississippi and Louisiana finish in the lowest part. And if you take a look, my son worked in Mississippi in the Teach for America, and you take a look at how people are treated in some of those counties and the racism and all the rest of that, which we no longer are allowed to talk about. I mean, I agree completely with both of Emily and Jeff that do-gooders at the national level have screwed things up often administratively and in other ways. There's no question about that. But at the same time, you have to balance racism, morality, access to minimum care, and all sorts of other things. And it's
Do you think, though, that the
balancing act.
national systems have effectively made health in those southern states better where we are today? Has it worked?
Well, it certainly kept the hospitals afloat, and it certainly funded the community
Well,
health centers that we
diabetic
talked about a
amputation.
minute ago.
Well,
All
let's talk
right,
about
so,
let's talk
whoa,
about diabetic
We got
amputation.
to, right? Nope.
Right, I agree with you.
Michael,
We have to stop. We can't talk about amputation.
we have to stop, Michael. All right. So I apologize to the audience. It was hard to get a word in edgeways to let you ask more questions. I
Also
know you
true.
have some, but it is time for our closing statements. So this is where the team will summarize their strongest points and address key counter arguments. We have Jeff will go first for the against team, and then followed by Stephen for the national team. So Jeff, can you make the argument for the local folks?
Well, I guess I'm certainly not going to dispute the fact that we are, as a society, underachieving in creating a healthy environment for our workers. And I think part of the problem that we're having is that we are spending so much money on our healthcare system that we don't have enough money to create the social supports and infrastructure to keep people out of the emergency room, to keep people employed, to keep them functioning, to keep them not depressed, and all the rest of that stuff. So we have an issue about, where we're investing our incremental dollars that isn't going to change. And of course, like right now, the incremental dollars are going to be going into defense and border security because a faction of our political system believes that that's where a lot of these stresses are coming from. We'll see if it has any effect on people's health. But I honestly believe that healthcare, part of the problem with healthcare and health in general is that it doesn't scale. And the fact that as we've gotten bigger as a society, we take less care of people. We seem to worry less about whether the families are getting where they need to go and creating a healthy environment for their communities. So I think the pressure to change it isn't going to come from Washington because frankly, the decision makers in Washington are bought and paid for. It's going to come, if it's going to come at all, from local people saying, we're fed up with the way in which our system is working, and we're not going to wait for Washington to change because it isn't going to change it. We're going to have to do something locally with the resources that we have. That's not a happy message at all, but I think it's a statement that our society's needs have grown beyond the system of government that we've created, and the nerve endings don't reach the fingers and toes anymore.
Okay, that's the final argument for the local team. Sounds like Emily approves, and Stephen for the national team.
So a general principle is what gets measured gets done. You get what you measure. What do we measure every minute of every business day? The Dow Jones Index. And so we focus on wealth creation, and that's killing us. We should measure how healthy we are and make comparisons with other countries. The State of the Union address is required by our Constitution, and we should make comparisons of our union with others. So if the president got up and said, we die younger than people in all the other rich countries and many poorer ones, then the media would pick this up and this would cause a furor. And it would be the first step towards improving our health, namely recognizing that we are living shorter lives, less healthy lives, keeping the undertakers busy. And once we become aware of that, just as when the Russians launched Sputnik, we suddenly realized we were far behind. And so we entered the space race and set a goal to land a human on the moon by the end of the next decade. We could similarly set a goal to not continue to see our shorter lives become reality, and in 10 or 20 years, be somewhere in the top 20 or 30 countries in what I call the Health Olympics. But we've got to start measuring it and reporting it to the American people. And the State of the Union would be a good start.
Thank you. Now it's time for our final poll. So if you'll just answer that poll, and we'll see who wins. And it's a
I'm
race to
hoping
the
that the
finish.
result shows completely unchanged. That's my personal. that's my
Undecided
personal
went
vote.
way up.
The people
That's
who
my
are local
personal
are now
vote.
national. No, yeah.
All right, that looks like it's stopped moving. Oh, nope, still moving.
That
We'll
would
give you
reflect the
another couple
national
seconds
consensus.
here. Oh my gosh.
Are you ready for
All
me
right.
to end?
It looks like it's a closing poll here. And can we put both of them up here? Wow, well, you
That's
gotta say
great.
that was a lively
That is very funny.
discussion.
I love it.
So
Hey,
looks like we've tied.
no,
We
no.
You guys-
persuaded a lot of
We
people
have-
to
we have
both
two
sides of the
winners.
argument.
Two winners,
That's
both
right.
sides win.
Oh,
Yeah.
there you go, Paul. That's right. All right. All right.
Well, because it can't be one or the other, right? There's a combination, there's a
exactly.
middle ground.
But they
Exactly.
reduced the undecided.
Yep. Yeah. So that's true. Yeah. Undecided lost and both national and local won, right?
Sure,
See that we're
but
more polarized now.
Yeah, you could look at it that way. All right. So thank you to our panel of guests. Really appreciate the work you did to enrich this conversation that we are having at HRC around the solutions for health and care. Thank you all for joining us today. You're all ruckus makers, and we aim to understand the root causes and find effective leverage points for transformation. And today's discussion of national versus local solution is meant to stimulate that innovation and help us think more broadly about solutions.
Hey, Jeff, in regard to your longevity, my father's favorite toast was, may you live as long as you want to and want to as long as you live.
Oh, that's good.
You can argue with that.
That's a good one. That's a good one.
That's very good. When I was younger, I told my doctor that I was in great shape because since I didn't exercise, everything was in mint condition.
There you go. Yes.
good as new, never been
Gotta
used.
change the
It's
oil.
never been used. That's right.
Still got to change the oil, Michael.
Low mileage. Yeah.
Yeah, as you get older, you kind of realize that doesn't work.